Good evening, all the aspirants present here. The next crash course session will be taken by Dr. Avishek sir. Thank you, sir. So you may start.
Okay, so I guess that this is a crash course session, and then we'll discuss few based on the questions. The DKA, that is diabetic ketoacidosis management, which of the following if a diabetic patient presents with blood sugar of more than 200 with a bicarbonate of less than 15. Number two is that if the ketones increase, then it indicates more severity. Number three should be treated with fixed dose insulin infusion. Four, during management, subcut insulin is started if sugars are controlled on IV insulin, usually 2 to 3 hours after the IV insulin. And progression can be monitored with urine ketones. So what are the options? I mean, I'm expecting true and false options. True and false. So it's, I mean, you can answer in which of the following is true. Okay. Let's see who are right. As of now, I'm getting few options. Actually, no. I think one option only. Someone only has answered. So this question, actually, the correct answer is 3. That is, should be treated with fixed dose insulin infusion. When there is the presence of hyperglycemia, that is, as per the traditional definition, sugar should be more than 250. Although yes, the current JBDS does say that 200 above is also accepted. Ketones bodies has to be positive and bicarbonate less than 50. So ketones has to be positive either by urine stick, but more than +2, or blood ketones, that is more than 3 millimoles per liter. So option A is incorrect. Option 2 is ketone does not indicate the severity. It is only indicates the lack of insulin, but the severity is dependent on the pH. So there is a classification of diabetes. If you go and read that, it is dependent on the pH, the bicarbonate levels, and the clinical scenario. So that determines the severity, not the ketones only. Should be treated with fixed dose insulin infusion. That is actually correct, because whenever a patient with DKA comes, you tend to start off with a 0.5, 0.1 units per kg of insulin stat, followed by 0.1 units per kg per hour infusion. So it's a fixed dose, right? So it's not a typical ICU patient where you manage as per the sugar requirements, you divide by 100 or 150 and run the infusion. So in this case, it is actually true. During management, subcut insulin to bolus, IV to subcut insulin switchover is dependent on the resolution of acidosis. Whenever the anion gap closes, patient is about to eat, then only the switchover occurs. If the anion gap is open, you cannot switch over to subcut insulin. Regular subcut insulin you cannot switch over to. And progression cannot be monitored by urine ketones because they tend to be positive for more than a week. So only the blood ketones has to be corrected. So this is based on few of the conceptual things. Which of the following are complications of decay? So which of the following are complications? Known following complications of decay. So if this is an open-ended question, so it can happen that the patients can have any answers per se. First, I'll take some answers, quick 30 seconds, and then I'll go for discussion of the individual components. So this is actually a multiple choice question. Almost based on different exam scenarios where sometimes multiple choices are correct. So which of the following is correct? Is everyone audible? Not getting any answers. Okay, so I'll decipher this. Okay, A and B, someone told. Okay, A and B both are correct. And you have fourth option that is also actually correct. So except for 3 and 5, you can have everything. So you can have a insulin dependent, insulin mediated hypokalemia and hypomagnesemia during a rapid correction of blood sugars. If your blood sugar is above 600 and if you're correcting very rapidly, so your osmolality can change in the brain and it can lead to sudden onset cerebral edema, especially in the young patients and neonates. So not neonates, but the young children. So that's why cerebral edema is also a complication. Hyperphosphatemia is rare. You can have hypophosphatemia. NAGMA, that is normal anion gap acidosis. Now, why this is a complication of decay? Decay per se causes high anion gap acidosis because of the elevated ketones levels. But during the resolution phase of decay, if you have given too much of fluids, especially normal saline, they can actually go into a normal anion gap phase. So you can have a normal anion gap acidosis in these patients as well, especially with the use of normal saline. So now option number 4, you can say it is debatable. It's not that it's a completely correct thing, but you can have. And coagulopathy as such is obviously not related to DKA per se. Question number 4. With regards to glycemic control in the ICU, which of the following is true? Risk of mortality increases with variable sugars. Option 2. Tighter sugar control at lower range is associated with better outcome in uncontrolled sugar patients. Option 3. NICE sugar and VICEP trial showed that intensive insulin therapy associated with better outcome and reduction in the insulin infection risk. Option 4. Capillary blood sugar is the gold standard in shock patients. And option 5 is sitagliptin associated with worse cardiovascular outcomes. So after each section, I'll give a brief 5 to 6 minutes overview of that particular part, the general theory part, then I'll move on to the next section. So this one, if you look at it, the regards to, so the first option, risk of mortality increases with variable sugars, actually is true. So there is something known as a coefficient of variance, which actually indicates that if that is increasing, so that indicates that is associated with higher mortality. So if a patient is having uncontrolled diabetes, you tend to keep the sugar in the ICU at a higher level, not strictly controlled to a very low levels, because this variation also associated with worse outcomes. Similarly, if the patient is having well-controlled diabetes or non-diabetes, their sugars mounting up to above 200 or to 300, that is also associated with bad outcomes. So option 1 is correct. Tighter sugar control has never been shown to be associated with a better outcome after the initial trial by Vanderberg et al. That was in surgical ICU patients. That was the only trial which showed that there was an intensive insulin therapy associated with better outcome. But after that, every trial is negative, and the recent trials are coming up with the data that is showing that there can be harm. So you don't go for tight sugar control, you go for a modest sugar control between 140 to 200. Even the recent paper on it, that is known as TGC paper, came in NEJM, and that has highlighted that even slight or mild sugar control of around 215 is also acceptable. So now people are moving towards something known as permissive hyperglycemia, just like permissive hypercapnia. NICE sugar and VICEP are the trials which negated the use of intensive insulin therapy, and the trials before to that were the ones where Vanderberg et al. Trial showed that there was some benefit with intensive insulin therapy. So again, it is the reverse. NICE sugar and VICEP exactly showed the opposite. In shock patients, we cannot rely on the capillary sugar because it is obviously erroneous. You have to sample from the blood and measure the sugar. Sitagliptin associated with worse cardiovascular outcome is actually true. Although this is not particularly related to glycemic control, but many trials have shown that sitagliptin per se is associated with cardiovascular outcomes worsening. Question number 5, DKA and HHS. This is very straightforward. Which of the following is true? Option 1, DKA associated with mortality, higher mortality. HHS typically have very high sugars. HHS require more insulin therapy. Severe dehydration and therefore enormous amount of fluid administration is the hallmark of DKA. And pH has to be acidotic in DKA patients presenting with vomiting. Which of the following is true? Any answer? Any answer for question number 5? Which of the following is right? So I'll discuss the answer. So the first option is actually incorrect. HHS happens in more elderly patients and it is associated with severe dehydration and relatively less insulin deficiency. HHS is having more mortality. And HHS, as I said, it is associated with higher sugars. Typically more than 800 is the cutoff. HHS requires less insulin therapy. So option 3 is incorrect. Severe dehydration, as I said, is a hallmark of HHS. And pH in a patient with vomiting, they can have mixed disorders. They can have respiratory metabolic alkalosis because of achlorhydria, and therefore they can have a mixed metabolic alkalosis, acidosis, respiratory acidosis, alkalosis. So they can have a normal pH as well. So don't rely only on the pH for diagnosing DKA patient. DKA.